my name is Lisa Torres. I am a speech-language pathologist and clinical specialist with Passy Muir. I will be presenting information on the physiological and cost-effective benefits of the Passy Muir valves. This video will complement our clinical video, which presents information on assessment, placement, transitioning, and troubleshooting issues with the Passy Muir valves. In order to understand the physiology of the Passy Muir valve, we must first look at a patient without the Passy Muir valve and with an inflated cuff on the trach tube. This patient is inhaling and exhaling only through the tube. Because the cuff is inflated, there is no airflow through the upper airway. With an inflated cuff, it can tether the larynx, and the larynx needs to elevate for an efficient swallow. Now, if you put your fingers on your throat and swallow, you can feel how the larynx elevates and how much it needs to elevate and move forward in order for the epiglottis to flap back and protect the airway. This allows protection of the airway and decreases aspiration for this type of patient. Another thing, because of the inflated cuff, is there's no airflow through the upper airway, and so there's a lack of sensation in the back of the throat, or the oropharynx. With this lack of sensation, the patients aren't able to feel their pooled secretions or any material that may go down into the throat. For example, if we were to drink a milkshake or to eat some pudding, and if it were to get caught in the back of our throat, we would feel it, and we would, we would clear our throats, or we would cough it up and swallow it back. And these patients are unable to do that. In addition, the airflow past the vocal cords allows the vocal cords to go into a closed position. Because there are baroreceptors, or pressure receptors, beneath the level of the vocal cords that require airflow to allow them to move into a closed position. So a patient with an inflated cuff has vocal cords that remain in an open position. So they have an open system here at the vocal cords and an open system here at the trach tube. And because of that, there is no pressure beneath the level of the vocal cords. Their lungs are open to the same atmospheric pressure outside the trach tube. Because they don't have this pressure, which is called subglottic pressure, these patients are more at risk for aspiration and have more difficulty swallowing than those patients who have a closed tracheostomy tube or are using the Passy Muir valve. The lack of airflow also does not allow the patient to have the sense of smell or the sense of taste. And the sense of smell and sense of taste is very important for these patients because the sense of smell and taste leads to a better appetite, and it also leads to improved nutrition. And nutrition is very important for these patients because they are respiratory compromised. Our goal is to get them the best nutrition as possible. In fact, many of these patients, because they lack that appetite and because they have such difficulty swallowing, actually will have some type of a tube, either a J tube or a G tube for feeding, because we are not able to feed these patients orally. This lack of pressure also does not allow the patient to have an effective and efficient cough. And without an effective and efficient cough, and because they can't sense anything that goes past the vocal cords, they are more at risk for aspiration due to that as well. Because the vocal cords are in an open position, and because they have no pressure beneath the level of vocal cords, these patients also do not have natural physiologic PEEP, positive end expiratory pressure. And PEEP is very important for our patients because what PEEP does is it allows the patients to have improved oxygenation. And what happens with PEEP is that there are small little balloons at the end of our lungs, and these little balloons, when they're open to atmospheric pressure, will deflate a little bit. They'll be closed. And because of that, there's less surface area or less area for the gas exchange to occur. So these patients with an open trach tube and an inflated cuff have reduced PEEP, and therefore they also have reduced oxygenation. Next, I will deflate the cuff in order to demonstrate an open position valve. All other valves other than the Passy Muir valves are open position speaking valves. With an open position valve, the diaphragm is already in an open position. So when the patient inhales, the diaphragm is already open. In order to close the diaphragm of the valve, the patient has to exhale up the tube to push the diaphragm to the face of the valve. And when this happens, the diaphragm doesn't completely close. The diaphragm will vibrate or oscillate, and some of the air still comes out through the front of the valve. In addition, to close the diaphragm of the valve, the patient has to exhale through the tube. And when this happens, secretions also travel up the tube and occlude the valve. So some open position valves, such as this valve, have a mechanism like a flip-top cap so that the clinicians can suction the secretions out of the front of the valve. Now, this type of valve does not create a closed system because some of the air is still traveling out through the valve. So this patient has the benefit only of communication. Next, I will demonstrate the physiological benefits of a closed position valve. First, you must completely deflate the cuff of the tracheostomy tube. Now, it is often thought that an inflated cuff of the tracheostomy tube helps to prevent aspiration. However, this is not true. The definition of aspiration is any material that has penetrated the level of the vocal folds. So even with an inflated cuff, the patient has already aspirated because the material has passed through the vocal cords and is just sitting on top of the cuff, waiting for someone to come along and to deflate the cuff, which then it will enter the lungs, or if the cuff is inflated, it may trickle past the cuff with time. So with the Passy Muir valve, you must first deflate the cuff, and then you place the Passy Muir valve. The Passy Muir valve is the only closed position no leak valve. So what this means is that the diaphragm of the valve starts in a closed position. So the patient inhales to open the diaphragm of the valve, and the air enters the tracheostomy tube and into the lungs. But at the end of inspiration, the diaphragm closes automatically, and there's no air leak back out through the valve. So what happens is the patient inhales through the valve, and the diaphragm opens, and then the diaphragm closes, which creates a column of air within the tracheostomy tube, which acts as a buffer from secretions traveling back up the tube and into the valve. Because the valve is closed here at the tracheostomy tube, all of the air is available to travel around the tube and up and through the vocal cords, allowing the patient to speak. That is the first benefit of the Passy Muir valve. Another thing is, because we have the airflow restored through the upper airway, the patient has restored sense of smell and sense of taste. And as I have said before, the sense of smell and sense of taste is very important to improve the appetite and therefore improve the patient's nutritional intake. Of course, because now we have deflated the cuff, the patient has better laryngeal excursion. This patient is now able to elevate the larynx, and the epiglottis is able to flap back and protect the airway. So they have a protection here, right above the level of the vocal cords. Now that we've restored the airflow and we have that pressure here beneath the level of vocal cords, instead of being in an open position, the vocal cords will go to a closed position. So we have closed vocal cords here, and we have the epiglottis flap back here. So we have our two natural barriers from aspiration in place once we have the Passy Muir valve on and the cuff deflated. Because of the restored airflow, we also have the improved sensation in the oropharynx. So this patient is able to better sense their pooled secretions or any of the material that they may be attempting to swallow. Because we have a closed system here and the closed vocal cords, the fourth thing that we've done for the swallow is we've helped to restore subglottic pressure. And independent research studies show that subglottic pressure helps to facilitate a better swallow and decrease aspiration in patients who are utilizing the valve. This study used patients with modified barium swallow, and they would have the patient swallow with the valve off, and the patient would aspirate. And then they would place the Passy Muir valve on, and the patient would not aspirate. The researchers in this study found that the swallow is not just mechanical, but also pneumatic as well. They found that with use of the Passy Muir valve and being able to close the system, they were able to theorize that the swallow is also a pneumatic system. That with the swallow we have two chambers. We have the trachea and we have the esophagus. And when we have a closed system here in the trachea and we have positive pressure on this side, we have negative pressure in the esophagus. And so the swallow works like a pneumatic system, and when the epiglottis flaps back and the pressure changes, the food is more easily able to go down into the esophagus. Another thing, because we've restored this pressure, is that we have a more efficient and an effective cough. So now the patient has the pressure to cough and to either expectorate orally the material that they are having difficulty with, or to swallow it back and manage it as we do. You don't realize that we are constantly managing our secretions and we're swallowing back on a normal basis. So now we've allowed these patients to do so. We've also helped to restore this pressure beneath the level of the vocal cords. So we've helped to restore PEEP, positive end expiratory pressure. And as I said before, instead of having those little balloons, those alveoli that are deflated, now because we have the restored pressures, these alveoli are able to open up like inflated balloons. And with this inflation, we have more surface area. So the surface area now allows for improved gas exchange. So you'll see in patients who are utilizing the Passy Muir valves, when you're using a saturation monitor, that their oxygen saturation levels will increase. Because the patient is now exhaling past their own natural anatomy and past the trach tube, they're using their expiratory muscles. Instead of just passively exhaling out through the trach tube, they have to exhale. And because they're doing this and using their expiratory muscles, it's helping with the weaning and decannulation process. These patients are utilizing the Passy Muir valve as a transitioning tool for decannulation. And studies indicate that when using the Passy Muir valve, the patient is able to be decannulated anywhere from 3 to 5 days sooner using the Passy Muir valve than with the standard capping method. Since this patient is utilizing their expiratory muscles, and since they're exhaling past their own natural anatomy, this patient, when utilizing the Passy Muir valve, is able to be weaned from the ventilator much sooner. This patient, if they're in an ICU, can be transferred out of the ICU and onto a medical floor much sooner, or if they're in the hospital, they can be transferred to a home type of setting much sooner when using the Passy Muir valve. Now, because we have restored the closed system, what we've done is we've restored this patient's natural physiological state. What we've done is we've, one, deflated the cuff, which allows the larynx to elevate and the epiglottis to flap back. Two, we've helped to restore the airflow so they have improved sensation in the upper airway. Three, we have improved the airflow past the vocal cords, which allows the vocal cords to go into a closed position, which helps to protect the airway. And four, what we've done is we've helped to restore that subglottic pressure. And because we have significantly improved the patient's swallow and decreased aspiration, and because we've helped this patient to manage the secretions much better, they have a reduced need for suctioning. So they have less time that the clinicians will need to spend with this patient, and they have less requirements for suctioning. In conclusion, with use of the Passy Muir valve, we have restored this patient to a more normal physiological state. We have reduced the complications due to the tracheostomy tube itself, and we have improved the overall health status of this patient. To summarize, the cost benefits of the Passy Muir valve include improved swallow, which decreases the patient's suctioning needs and associated costs, decreased aspiration, which may allow the patient to avoid a course of antibiotics for treatment of aspiration pneumonia, decreasing the possibility for the insertion of a J-tube or a PEG, improved weaning times, which results in transferring the patient out of the ICU or hospital sooner, and thereby decreasing the overall length of stay. With a Passy Muir valve for less than $1 a day, you will restore the patient's natural physiology, reduce the complications and related costs, and improve the patient's well-being and quality of care. For further education on the application of the Passy Muir valves, please visit our website at www.passymuir.com. There you will find our free continuing education courses, which include assessment and placement issues, transitioning issues, ventilator issues, dysphagia issues, and pediatric issues. You may also download the clinical instruction booklet, patient handbook, and request our free clinical in-service video.
The Passy Muir valves are prescription devices that can be purchased by physicians, patient care facilities, and home care equipment companies. We encourage you to contact us if you have additional questions, would like to receive more information, or to share your comments and suggestions concerning this video or our products.